Hey, welcome everybody to the UIC Global Health Colloquium. This is a, um, a meeting that's run by a number of different health science colleges at UIC, including medicine, nursing, applied health science, pharmacy, dentistry, social work, School of Public Health. So we're really glad to have you here. This is our last meeting of this year. It will start up again in September. For those of you who are first-time attendees, we'll send you an email and be in touch. We encourage you to come and invite your friends. The title of today's talk is Reimagining Mental Health Care for Refugees in Resettlement. We have an amazing panel that I'm going to be moderating. And so I'm going to give a few minutes of introductory comments and then we'll get into it. And the format today is we're going to have like an hour of dialogue between the panelists. I'll be asking them some questions. They'll be responding to one another. And then at 1 o'clock, we'll open it up to everybody so you could share your questions. We encourage you to post questions in the chat in the meantime, and then I'll either read those questions or call on you to ask questions verbally to folks. So, you know, given where the world is today, I hardly need to say anything to introduce the idea of refugees, because you see them in the media, you see them on television, you hear their stories, you feel their hardships, especially those from Ukraine. There's approximately 5 million persons who've crossed the border and become refugees. Of those 5 million, it's said that a small amount, 100,000, will be coming to the United States, though that's complicated in a way that we'll hear about soon. Of course, these are not the only refugees in the world. Recently, also, we heard about Afghan refugees and know that the United States has already accepted about 80,000 refugees from Afghanistan who are already here and starting to rebuild their lives in US cities. Of course, we all remember this tremendous war and crisis in Syria, which has led to some 7 million refugees, of which there's about 20,000 in the United States. In total, there's about 90 million refugees in the world right now. So the numbers are really astronomical, as high as they've ever been. And that's what we're here to talk about today. I want to mention that UIC, I think, has a pretty strong commitment to understanding and supporting refugees, as well as other kinds of migrants. But back in the day, when I first came here in 1995, we established a Bosnian mental health program with the state of Illinois and what used to be called Travelers and Immigrants Aid, what's now called Heartland Alliance, and provided mental health services and psychosocial services to thousands of Bosnian refugees living in Chicago. And I think there's been a number of partnerships over the years between UIC and different refugee resettlement agencies. Mary Bunn, one of our panelists today, is working currently with the Kovler Center and has herself worked at Heartland Alliance. And I know that there's a lot of interest among students and trainees in refugees and working with refugees. So I really appreciate the commitment of folks at UIC towards refugees. And hopefully this dialogue today will build on that in ways that will encourage more people to take an interest and get involved. So who have we got today? We have an amazing group. I could spend hours introducing them. They have done so much great stuff, but I'm just going to give about a sentence or two on each person. So we have Beth Farmer, who's a licensed clinical social worker, and she's the Director of Safety, Education, and Wellness at the IRC, International Rescue Committee. And Beth has a long history of working in persons who've experienced displacement and trauma. So thank you for joining us, Beth. We have Dr. Heidi Ellis. Heidi is a longtime collaborator and friend of mine, and also a really nationally and internationally known expert in refugees, especially children. She's associate professor in psychology and psychiatry at Harvard Medical School and Boston Children's Hospital. She's a licensed clinical psychologist, and she directs the Trauma and Community Resilience Center at Boston Children's Hospital. She's part of the National Child Traumatic Stress Network. We have Ann Richard. Ann Richard joined the Freedom House as a distinguished fellow and Afghanistan coordinator in 2021. But previously, Ann served as Assistant Secretary of State for Population, Refugees, and Migration in the Obama administration from 2012 to 2017. And she was also Vice President of Government Relations and Advocacy in the International Rescue Committee. Thanks, Ann, for joining us. We have Hadia Zarzour. Hadia is a licensed therapist and a Syrian community leader and advocate. She came to the US from Syria in 2009 on a Fulbright scholarship. And since then, she's been engaged with the Syrian community here and in the Mideast and focused on psychosocial support and mental health. Thanks for joining us, Hadia. And then we have Mary Bunn, who's here at UIC. Mary is a research scientist in the Department of Psychiatry and a faculty member in Center for Global Health. She focuses on community-based health prevention and care intervention for survivors of war and political violence across the migration continuum. And as I said before, she's doing some really exciting work now with Afghans as well as Syrian and Iraqis in the Chicago area. So thanks, Mary. Thanks to all of you. So I am going to get right into it by posing the first question. So the question is to you, Ann. Ann, could you help to orient the audience and provide a brief overview of what does the Refugee Resettlement Program look like?
Thanks very much for the invitation to speak on this panel today. Thanks, Steve, for that kickoff question. In a normal year, and we haven't had a normal year in quite a few years, we see that overseas, the UN Refugee Agency, which goes by the initials UNHCR, or US Embassy sometimes, will refer refugees to the US program for resettlement in the United States. They're also sometimes referring refugees to other countries' programs. But traditionally, the US had, pre the Donald Trump administration, the largest resettlement program of any country. And the refugees would be encouraged to apply for resettlement. They would be vetted in several ways. Their backgrounds would be looked at. There would be security checks done and also medical checks to make sure we weren't bringing folks with contagious diseases in to the US under a government program. And so the general process to do this took on average between 18 and 24 months. And then the International Organization for Migration would help these refugees go to the United States, usually by airplane. And they'd be met at the airport by local groups that are one of the 9 networks of resettlement agencies across the US that on shoestring budgets welcome the refugees, bring them to a new home, probably an apartment where they'd have a meal waiting for them that was culturally appropriate, and then come back the next day and help get the kids in school and help the able-bodied adults to get to work. And so this program, which continues every year, but just fell to really low levels during the Trump administration, is being built back up by the Biden administration. But then two surprises have brought have brought significant numbers of Afghans, and then also will be bringing significant numbers of Ukrainians to the U.S., which is the fall of Kabul and the desire to evacuate people who had worked with the U.S., who were in danger because of that, to the U.S., brought in under special immigrant visas or under humanitarian parole, and brought to U.S. military bases, and then resettled. And so that's a very different way of doing things. In fact, I didn't think that was possible to do post 9/11, to bring in people so quickly. But the U.S. proved it could be done, in part because so many Republicans and Democrats felt that this type of emergency program was owed to our Afghan allies. And then the other program that's been announced but not yet carried out is to bring in 100,000 Ukrainians to the U.S. as well. And so the resettlement agencies that do fantastic work across the U.S. are really under strain now, trying to figure out how to accomplish all of these goals at once after a period of time where they were really starved for resources.
Mm-hmm. And could you also say what's special about the way that Ukrainians are going to be resettled now?
My understanding is that instead of just taking applicants based on who's the most vulnerable, which is the way the resettlement program has been run in the past, the White House is very interested in bringing in Ukrainians who have a personal or a family connection already in the United States. So someone inside the United States knows this individual and is willing to help sponsor their arrival in the US. So that is different. Usually it doesn't matter if you know someone in the United States already or not, in terms of refugee resettlement. We brought lots of people who had no ties to the US when I was a assistant secretary. You know, we were bringing people from Burma, we were bringing people from Nepal, we were bringing people from Congo, and they didn't necessarily have any connections to the US in advance.
Mm-hmm. Okay, let me ask, does any other of the panelists want to come in at this point and say anything more about how refugee resettlement program works?
What did I leave out, Beth?
I don't think you left anything out. I mean, I think that right now it's a particularly challenging time. As you said, a lot of people were coming in a very short amount of time. To give you just an example, is we had more people in some of the IRC offices come in 4 months than they had come in 2 years. And you overlay on top of that COVID, as you said, the kind of decimation of the structure and the offices. And then a particularly challenging hiring environment. All of those things have made the current resettlement work even more difficult. And at the same time, we're very grateful to also have so many more people have a connection to safety and hopefully permanency within the United States.
Anybody else want to add in?
I guess just to remind folks that this program has always relied on the use of volunteers in addition to groups that are really, you know, social services oriented, these refugee resettlement offices, to start life over in the US. And since last summer, there's been an outpouring of people who want to be volunteers to work on this, which is great, because that is definitely needed. But it also, this is not a luxurious program. And as we'll talk later, you know, this program is for people who've already been living in fear. Sometimes they've already been traumatized, and they're incredibly resilient and able to start over again in a way that I don't know if any of us could pull that off. And we wouldn't want to have to try. So these are people who have fantastic survival skills. And when they come to the US, though, their struggle is not over, because they have got to, the program expects them to get to work and get self-supporting within a very short period of time, 3 months or a little more sometimes.
Well, thank you, Anne, for all that you've shared so far, and also for shining a light on where we want to go, which is to talk more about the mental health and psychosocial challenges that these folks face, and that these programs also undertake in trying to provide services. So now I want to turn maybe first to Heidi, and then to Hadia. So what are the most important lessons learned or successes in your work with the mental health and psychosocial issues facing refugees? Heidi.
Thanks, Steve. Thanks for the opportunity to be here and for that question. I would say, I think we can say in one word what I found to be most important, and that's community. So in the work we do, communities are our greatest asset. And what I mean by that is programs that we develop kind of in partnership, growing out of the strengths that are already present in a community, embedding within a community, building on natural leadership in a community. Those are the programs that are going to be most accepted, appropriate, helpful. I think this is where refugee work has moved, and I think that's one of the greatest successes of what we've seen. And there are a lot of different ways that can look. There are ethnic-based community organizations that take leadership roles. There are individuals who take leadership roles. But I think the more we are community partnered, the more successful we're going to be in making sure that we're providing something meaningful, useful, and what folks need.
Can you tell us more about, like, how do we help refugees who are having mental health and psychosocial issues? What's that look like? What shape does that take?
I think my first answer to that is maybe it's helpful to say what shape it doesn't take very, very well, which is here's a mental health clinic with a sign over the door that delivers a model that's been developed on other populations, and we sit in our office waiting for someone to come and take advantage of our services. That's where I started 20 years ago, and it went nowhere. Nobody wanted those services. Nobody was coming to the office, or if they were, it was simply to help me get my kid back in school. This isn't the problem. I have other things that I need help with. So I think, if we start by saying that's not where we want to be and how we want to be doing it, then it opens up the world of creative thinking. And there are a lot of wonderful models out there. Many of them developed by people on this Zoom call. So Steve, and I'm thinking of some of your work as well. But I think what we do needs to think a lot more holistically about what are the whole range of stressors and needs that a child or family might have. This is not just trauma and PTSD. There's a lot more that's going on, and sometimes other levers and other interventions are going to be more effective and more helpful. It's going to be thinking about how do we partner with someone from the community, if I'm an outsider providing the services, so that what we're doing is not just in the literal language of the family, but is in the sort of cultural language of the family, that what we're doing makes sense and builds on maybe what families are looking to do and the goals they have and the way they're operating already. So I think community-based work, getting into the schools, getting into the community agencies, maybe partnering with pediatrics offices, thinking systemically about where families are going anyway already and feel like they're being helped and where there's some trust. If we can embed our services in those systems, I think we're going to be a lot more successful than if we're trying to convince people to come over into the door that says psychiatric clinic.
Okay, fair enough. So Hadia, what can you add to that? You are a refugee yourself and a provider for refugees, so you must have different perspectives on this issue.
Yes, thank you for having me, Steve, and for this opportunity. Yeah, actually, the timing when I was here, it was really critical. I was ready to go back home in 2011 after I received my master's, and I couldn't go back. It was so dangerous. I had the privilege to work at a community mental health agency called Asian Human Services in Chicago. And that gave me a lot of experience about how the and knowledge about how the resettlement system works. We had people from different backgrounds, like staff who spoke 15 different languages, and I could see the importance. Actually, when the Syrians became refugees, it was an amazing, eye-opening experience to how can I be like a more empathic therapist, and what do they really need? So we can talk. I mean, learning the stories of different refugees is so important. That can be very empowering in healing them, listening to them deeply, utilizing the role of interpreters also to help understand the culture, so we can communicate better to refugees. So since, as the Syrian refugee crisis became the biggest in our time, most of my work has been focus on founding organizations that can support the refugees. So there's the Syrian Community Network here in Chicago, and in San overseas in Turkey. The beautiful work, as Heidi mentioned, the idea of community and how we can activate the bigger community to help the refugees, and at the same time, so we work as a bridge between the resettlement agencies to provide this cultural component and provide the aid after, as Anne said, it's limited time that the resettlement agencies provide support. And the bigger Syrian community who has been here, we have in Chicago, we have a very well-established community since the mid-60s and early 70s. So we work on activating this bigger community so they can support, whether in providing jobs, whether in financially helping with the school system, helping with explaining the healthcare system, and I mean, and another like very very special component, like a very special factor that we're very proud of. We have the mentorship program, and that was it was focused on educating American families on the psychosocial, the political and social story about the Syrian war, telling them that it's a revolution. It's based on those values of dignity and freedom. So they felt very interested in the story. It's not like when you say there's a war in a country and we have those refugees. So we connected them. We connected American families to Syrian families. They would see them on weekly basis. As it was mentioned, it was all volunteers. So that was beautiful that they come every week, and they share food. Syrians are very generous and hospitable, and they share their food and they share their stories of resilience. So and we could see that every time we're having an American family coming, they would say, we have other friends. Do you have another Syrian family that you can introduce us to? So that was really beautiful introduction even for the Syrian families. They felt like more adjusted because they're connected to American family. So again, back to what summarizes all is what Heidi said, the idea of community and really having this ripple effect.
Thank you. One of the questions in the chat says, what are the more common mental health challenges seen among refugee children, and how can those be addressed? You panelists are shining a light on the strengths and resilience and positive strategies, but let's talk about the challenges. There are elevated rates of post-traumatic stress disorder, depression, behavioral problems, learning problems. The surveys I've seen say somewhere between 20 and 40%. I remember in the group of Bosnians that we resettled many years ago, there was 66% of adults had PTSD at first, and it went down to like the 30s by 2 years. So there are these issues. So could you say something more, Heidi, maybe about those challenges and how are we addressing those?
Yeah, and the challenges are real. Like I'm thinking back to those kids who, I think I said in the beginning, I started trying to work out of a mental health clinic, and there were kids who were referred to me. They didn't want mental health services. They wanted to get back in school. But the reason they were referred to me is they weren't able to manage in school. They were, really experiencing emotional dysregulation, maybe kind of flooded with intrusive memories, and so they did need some support and help. So I think the thing to remember, or what I've learned though, is that it's not like there's a one size fits all, let's do PTSD treatment, because the challenges for these kids and families, it manifests in many different ways. And sometimes the most helpful thing we can do is around removing some of the social stressors in a family's life and thinking about, how do we make sure families have the basics that they need and take the stress out of food and housing, and making sure they understand how to keep their kids enrolled in school and what that entails. And sometimes mental health treatments that have been effective in other populations are very effective here as well. So thinking about, when do we bring in more focused treatment around depression or PTSD, but that when we do it, we have to be conscious of the whole. Simply trying to focus in on a specific mental health problem, if there's a lot of social stressors going on, if the child and family are experiencing conflict around acculturation differences, there often is more to it than a single mental health problem. And so taking that more holistic view and thinking about how to support the family and recognize where things are going well and building on those strengths, I think that's going to be most effective.
Anybody else want to come in on this?
I would just say that I think one of the things that we have found to be really effective is empowering the caregivers with information about how they can support their children, and providing some really strong psychoeducation and skill building for them, because they're the ones that are with their children the vast majority of the time. And of course, they know their children best and they're most invested in their success. And so creating that kind of training capacity and support for the caregivers so that they, not because they're not good parents, I'm not talking about parenting skills, but they've been faced with extraordinary circumstances. And I think any of us, when we're faced with extraordinary circumstances, need more skills to be able to manage those circumstances. And so that investment tends to pay off many times over, but it also is a way for caregivers to reflect on maybe some impacts that they've also had from forced displacement, and also to use the skills themselves. And we found that to be a really effective strategy. But I couldn't agree with Heidi enough that really looking at the whole and all of those pieces and where the biggest stressors are, and having a very individualized approach is so critical.
Mary, you're someone who's thought a lot about families and the healing power of social processes. Want to come in on this?
Yes, of course. I think what I was thinking about just now, as you were talking about children and their mental health needs, is certainly stabilizing the social system, but also thinking about broader structural stability. And I'm especially thinking about work I've been doing this year with Afghan children who, were residing in U.S. military bases for upwards of 6 months, and then are resettled to communities. And because resettlement agencies are struggling to keep up with demands, they're in temporary hotels, and just the ways in which, the importance of prioritizing those kinds of routines and structures for children and families' whole well-being. I think, we have to start there, thinking about the broader structural landscape for kids as well.
So let's move on and talk about gaps and challenges. So Beth, what are the biggest gaps and challenges for mental health and psychosocial services for refugees?
Thanks. I appreciate the question, and I would say that I think it's important to note that I think the mental health system in the US is extremely broken for everyone, difficult to navigate, particularly underfunded, focuses a lot on pathology. It's not particularly preventative focused. So I think that exists just as a foundation. And then you add additional factors that have to do with language and culture, as well as the fact that the US mental health system is very predicated on a Western worldview and what is normative and what is healing and what is meaningful. And you add all of those things together and it can really many times not be particularly helpful or accessible for many people who've come to the US that are forcibly displaced. I would also say, to Heidi's point, at least for what we fund within mental health, what is funded tends to be very individualistic. What is reimbursed is very individualistic treatment. It is much harder to get community-based treatment funded or family-based treatment funded. And again, that kind of gets to that Western worldview where we really value that individualistic approach a lot. But that tends to not be a good match for many of the families we serve, where their strength and their resilience and their healing is coming from their family and community. And another thing that I would say is we don't put enough people in thought leadership positions and positions of power that have lived experience that can innovate with what we do, so that we're really having more and more responses that are informed by different worldviews. And a couple other thoughts I have is that we tend to think in the US, the way our mental health system is structured, is very economically driven, and it's designed to be short-term. And you're supposed to meet these, having been a director of a community mental health agency for a long time, people are supposed to meet certain objectives, certain measurables with how much utilization they have, or else they're supposed to be discharged from services. And that doesn't really take into account that healing occurs over a long period of time in many different ways with many different entry points to it. And so I just think the way that what is funded in the US, besides being terrifically underfunded, is just not really set up to serve people with really complex needs, whether they're refugees or they're other folks.
Mm-hmm. Thank you, Beth. How about you, Mary? You want to come in on this?
Yeah, thanks. I think picking up on what a number of other panelists have said, just drawing attention to stressors that exist in the resettlement environment. I'm especially thinking about structural barriers and violence in the form of racism and xenophobia relative to refugees' mental health. And again, I'm thinking about this most recent work with Afghan families. Had the chance to spend a good amount of time at these US military bases and interviewing children and youth about their priority needs, what they were thinking about. And I was struck with the clarity with which these children and young people express concerns for their safety and well-being when they were to be resettled in communities. You know, kids asking, will I be able to wear my headscarf in my new community? Will I be able to pray at school, for example? So, you know, it's hard to think about mental health, you know, how do we really innovate and provide services to the individual, to the family, or even communities without also grappling with these bigger social drivers of mental health. So I think that's not a new barrier. It's not a new challenge, but it's one that we increasingly need to reckon with and kind of integrate, I think, into our mental health service models. A lot of people have already mentioned that we are at this super challenging moment in terms of the resettlement system. Afghan families arriving, soon to be Ukrainian, coming at a time when the resettlement system is really rebuilding after 4 years of devastation and defunding under Trump, and all also in the face of COVID. And I think it's kind of tempting to think about that as a unique set of converging factors, but in some respects, we don't really have assurance that we won't find ourselves back in this place again. The kind of waxing and waning nature of public will around supporting refugee and newcomer populations, I think, is a sadly consistent thread. And then what others have said is that even in good times, we really don't historically robustly support mental health and psychosocial care for refugees. And then I think the other thing I wanted to mention relative to opportunities, but challenges relates to really delivering culturally tailored services. Culture is not just this factor in treatment, right? It is the total picture. It's the water in which we all swim in. And I think we're really challenged in this field to provide culturally tailored services to constantly diversifying refugee communities. And that work, as everybody has said, takes deep partnerships and collaborations and time. And so, you know, we are there's more work to do there, and to sort of figure out how do we go about that kind of deliberately, take that deliberate approach to work and do so in a way that is responsive to really urgent and rapidly evolving needs.
Thank you. I'd like to come back to Anne.
Yeah, when we were preparing for this panel and talking about different things we could raise, I was reminded of an experience I had about 10 years ago, where I went to the Center for Victims of Torture in the Twin Cities of Minnesota, and was getting shown around, and they talked to me about the services they provided for refugees who had been tortured or who had terrible stories. And I said to them, so do you get a lot of Congolese who have been victims of rape during wartime, for example? Because that was a big issue we were struggling with. And they said, well, actually, no. The folks who are making time to come in and see us and get help are people who've been in the United States for 20 years and are from the Balkans wars and had terrible things happen to them. But their main priorities when they first got to the US was the survival of their families, getting to work, putting down roots, getting, the safety of their families, getting the kids educated, getting jobs that would support the family. And so they said only after 20 years have the heads of household or, the parent figures thought to themselves, okay, now I'm free to look after myself. And I have these lingering pains and thoughts that come from what happened 20 years before. And that left such a big impression on me that this is not something that can be part of a welcome package to the US. And you say, okay, and here's your mental health half hour, and good luck with that. Instead, this is something that could arise or be something that people could be more prepared to take on sometime later. The flip side of that is the tough love approach that is the U.S. Refugee Resettlement Program, where we insist able-bodied refugees get right to work and support their families. There is a positive part to that, because some other countries, in trying to be more generous, will not pressure refugees to get right to work, and they will instead let them live in dormitories, try to teach them the language, and give them time to adjust. And what we found is actually the US approach gets people, it thrusts people into our society and gives them a role in society, a place in society, and they become more self-sufficient faster. Now, I think it's too fast, but I do think there's a piece there that is actually good for the mental health of the refugees. That is something that other countries can learn from our example.
Okay, thank you. Well, you've all pointed out some challenges and gaps. And so I'm wondering, what are you working on to change with respect to mental health and psychosocial services for refugees? I mean, if it's being built back nowadays with these new refugees coming, or old ones who are circling back for services, what are we just going to do the same things we did before, or are we going to do different things? Mary, you want to start?
Yeah, sure. Yeah, hopefully not. Or, I think, yeah, we are evolving, as somebody who came into the field initially as a clinician about approximately 20 years ago. It's possible to see a lot of progress that's been made in that time. And yet, there's still a number of important barriers to overcome. I think, many have brought this up as a kind of feature of our refugee service system, which is the kind of fractured health ecology available to refugees. You sort of come into the resettlement system and get intensive supports for an initial period of time, and then there's a bit of a cliff in terms of organized and structured supports. There's essential roles being served through community-based organization, ethnic self-help, but I'm talking about sort of formal services available. And so I think, and then sort of later downstream, we have some specialized mental health services and incredible practitioners who've developed skills to work with these clinically complex cases. But I do think there is an opportunity to think a lot more about prevention and supporting refugees right from the start. I mean, the thing, the sort of additional point to add to what Anne said is that, not every refugee who comes to the United States needs specialized care for PTSD. It's actually a much smaller percentage of the population than we might otherwise think. And those individuals and families may really not need those kinds of services if we can start very early on in supporting the natural strengths and assets that they have as individuals and families and as communities as a whole. So I mentioned the work we're doing now with Afghan families, which very much is motivated by that spirit, doing that in collaboration with partners at Boston College. Also working, we've been lucky in partnership with Heartland Alliance and through some private foundation, we're doing work in that area now with Arabic speaking refugee families to really think about how can we sort of front load support early on, and not only that, like what are the spaces and places that refugee families are already going, and how can we design our services with those settings in mind? So actually bringing kind of a design sensibility to how we think about developing mental health. I know you'll appreciate that I mentioned design, Steve. I
was thinking of the library, the example of the library, which you've talked about. The library, which is a place where kids go after school, where parents go with kids and hang out. So the idea is, right, to kind of somehow introduce mental health or psychosocial supports in a place like that, rather than what Heidi, the counterexample Heidi gave us. Here's our mental health clinic, come, right?
Absolutely, yeah. And I mean, and there's been all kinds of innovative work like that being done over the years by service providers. But yeah, to sort of start take a truly ecological, place-based approach and say, where are refugees? Where are families? Let's go to them. We had a lot of years, I think, square hole round peg, like we have this beautiful shiny intervention, but it's not fitting into this setting where people are convening. So yeah, sort of flipping the logic on that. And then I think also thinking about sustainability really right from the start. How can we design our partnerships, design our programs and services so that we think about what gives them the best chance to be sustained in the long run. And as Beth said, some of these questions come down to what's reimbursable. Right now, prevention services are not reimbursable without a clinical diagnosis. So we have to figure that problem out, because it just doesn't make sense to wait until things escalate and worsen until we have the chance to intervene. Go ahead.
Thank you. Let me circle back to Heidi and then Hadia. Heidi, we're on the, I guess we're on, you ready?
Sorry, I was muted.
No problem.
I have a few things I would add here, some of which are very reinforcing of everything that's been said thus far. The first thing I would say is at our center, we feel really passionately about the importance of partnering with cultural brokers when we provide care. Cultural brokers are individuals who are from a community, also have particular expertise in understanding the mental health culture in that world. And they're more than interpreters. They are kind of the broker between a mental health provider and the community, in the sense that they can help everyone understand some of the nuances that otherwise might be unspoken in the room. And they can play a really critical role also in terms of being a trusted liaison. They may know the family or the community already. They may be embedded in certain ways. And the way we do it in our program is that clinicians and cultural brokers are equal partners in working with a family. So it's not like it's a one over power down relationship. It's really an equal partnership in the work of coming to understand a family's needs and how to help them. So that's one of the areas that I think we can improve upon, and that we've begun to see take root in different agencies around the country that we work with. The second thing I would say is just echoing what Mary said about the spaces and places where people go already. So we do a lot of thinking about embedding within service systems. We do a lot of work in schools. We do work in the home. We try to connect all of that so that we're really meeting families and kids where they already are and where trusting relationships already are happening. So those are two areas. And then the third is, again, I think we've sort of referenced it already, but really broadening our thinking around what mental health supports look like for a family, so that we don't myopically end up doing trauma treatment when what is needed is something sort of broader and more supportive. We have a phrase that we use in our work where we talk about a family's primary source of pain. And we really like to hear from families about what they think is causing the biggest problem in their family and what their greatest need is, because it often isn't what an outsider coming in and looking at a family thinks it might be. And it might be something more around, the need to have a space to come together to pray, or it might be around the stress of not knowing if a parent can both hold down a job and respond to the school when they call, or it might be around something different. But we start by trying to understand a family's primary source of pain and do that work. And what we have actually found is, in some research we found that when we address some of the social stressors in a family's life, for many kids, that takes care of the worst of their mental health symptoms. And they don't need focused mental health care if some of those larger family system stressors are attended to. There are, of course, sometimes when more is necessary, but I think it's a really important, as a mental health professional, it's important to remember that my hammer might not be what everyone needs. And so maybe what I'm best able to offer is to say, you tell me what you need and let me see what I can do to help either connect you with people who can do that, or to take that on as part of my direct care for your family.
Thank you, Heidi. Hadia?
Yeah, and to that point, speaking of the holistic approach, I've been working on reducing stigma to mental health with the Muslim community across the country. I've been partnering with different religious leaders to bring this understanding of what's providing mental health is, what's like a psychological first aid is for different imams at different mosques. It's been challenging, but I've seen it changing in the past 3 years. And as we know, for refugees, mosques are easy to access, and they come for spiritual support, for social support, and sometimes for financial support. So to have this mental health dialogue and changing this culture and changing the stigma, I think can be very powerful in providing services. I would say we had a huge victory at my mosque here in the southwest suburbs. We just started like a mental health committee at the mosque, me and the other two psychiatrists, where we had 500 people, over 500 people participated in a needs assessment that we sent out. And then we had a launching event back in February that talks about, what is mental health, really breaking things down, like very simple to people. And again, to encourage having this conversation. We had over 250 attendees. Half of them were men, which is something significant we don't always see. Usually we see mothers when they're bringing their children, but to have men and to have religious leaders, I think that's very, very promising. We have seen in different mosques a lot of Afghan refugees coming also to the mosque. So we're trying to build this culture of talking about mental health and breaking the stigmas. Imams have been talking in their sermons, the Friday sermons also, about it. So yeah, empowering those institutions, Muslim institutions, can play a critical role in providing mental health services.
I have more questions and we do have time, and I want to open it up to the audience soon, but on the kind of hopeful example that Heidi just shared, I want to ask the others of you, what gives you hope? It's a very dark time right now. There's more refugees than ever, and we have so much work to do, but what gives you hope in this space in terms of addressing refugees' mental health and psychosocial needs? Anne, you want to say something?
Yeah, I went to the funeral of one of my mentors last week, Madeleine Albright, who came to the United States as an 11-year-old refugee and ended up being Secretary of State, which I think is a lot to expect of any little girl, especially refugee girls. So I'm not saying that we should encourage that kind of a career progression, but what I am saying is don't count those kids out, because what I've seen over and over again is the incredible resilience of children. It's just been amazing how quickly they learn languages, how quickly they pick up what's going on in school. If we can get them into school younger, they can become fluent in English. They can become incredible cross-cultural bridges. We have to be careful, though, of course, that they then become, and this has happened for generations, they become the representative of the family and displace the male head of household. They'll become the one who has to be presented to deal with insurance and school administrators and all sorts of authorities, and so that's not doing them a favor. But the fact that they are so incredibly successful over and over and over again, that gives me hope. They make great Americans is what I'm trying to say. And, we are, when we some of our propaganda is that we are enriched by taking in all these refugees. Well, guess what? It's true. It's absolutely true. And so that gives me hope.
Great. Beth, how about you?
I would say coming up with some of these, even though there's some concerns, and but being able to see the U.S. move very quickly to support people being evacuated from Afghanistan, particularly our allies, seeing the innovative approaches that they're using with Ukrainian refugees, being able to move quickly. You know, I have some significant concerns around equity and what it means for other refugee populations, but would very much like to see those be a bar that we aspire to for other populations and other circumstances, because the truth is that all people fleeing from conflict and persecution and oppression deserve safety. So it has given me hope that in the last year in particular, we are willing to reopen our doors and think innovatively and give people some level of safety and sanctuary. And now I'd like to see that again be the watermark for other populations who also deserve those same things.
Yeah, there's a question in the chat about midterm elections and if the House and Senate become majority Republican again, wouldn't we just go back to the Trump era? Not necessarily. I mean, we might, but what has been encouraging is that the Afghan Adjustment Act, which is being discussed on Capitol Hill, it hasn't been attached to any must-pass legislation yet. This act that would help Afghans who came in under humanitarian parole to know that they were welcome to stay for longer, and they wouldn't be deported in a couple of years. This is getting support from both the right and the left of the political aisle. We see veterans groups speaking up on behalf of helping Afghans and bringing more Afghans to the United States, and they help bring Republican members of Congress to agree with Democrats who are pro-refugee that we should be doing more. And so that's a different political dynamic than we've seen in quite a few years.
Mhm. Mary, do you have any thoughts on what gives you hope?
Yeah, I mean, one obvious source of hope for me are colleagues like Heidi. She gives me hope. And you know, we know there's similar visionary, powerful community leaders in all refugee communities. There will be in the Ukrainian community. I think the question is just how do we really systematically amplify their voice, support and accompany them, empower them so that they can do the work of leading that is so needed for all of these reasons we've aired today. I was, you know, in reflecting about this question for today, I was also thinking that, you know, having come into the field shortly after 9/11 happened and feeling like we've been kind of battling against increasing discrimination and anti-immigrant sentiment since that time, and which is very much still present, but I do feel like there's a growing movement, let me say, and of collaborators and colleagues and advocates in this field. And there's signs of that for me in several different ways. Steve, you mentioned even within UIC, there's so many students and colleagues who've come forward, researchers interested in this area. We have huge interest, seemingly, you know, suddenly over the last couple of years in supporting asylum seekers through their asylum process. We have this coalition for immigrant mental health that is based in Chicago, but is nationwide and is really bringing together advocates, researchers, community members, practitioners, and cutting across kind of forced migration experiences. So, you know, all those are encouraging signs to me. I'm a devotee of Judith Herman, and one of the things that she really underscores is the need to and the imperative to work in collaboration in this work. And so it just feels like, at least from my small vantage point, there is a, you know, growing swell of supporters in this space, and I'm kind of hanging on to that as we navigate against these broader challenges, systemic and otherwise, that we've all talked about.
Thank you, Mary, for that. I'm feeling pretty hopeful with the hope that's been shared so far. I want to open it up to the audience. We still have over 100 people on. I've been following the chat. And I'm gonna, if people put more questions in, I'll try to deal with them. And I'm gonna probably invite some people to say their questions. So put your question in there first, and then I'll invite you. But a couple of people have brought up, like, are there good ways to get training to either caregivers or to non-mental health persons who are working with refugees? Like, essentially, what do they need to know and do to help support refugees? And are there trainings and resources to support them? Who can answer that?
I think it depends on what person and kind of what their scope and role is. I mean, I think a good foundation for anybody in any sort of direct service would be to really understand trauma-informed practice and some of those trauma-informed principles. But then there's quite, there's wonderful trainings, again, depending on the scope and role, like IRC has safe and healing learning spaces for educators, which is fabulous and doesn't just benefit refugees, but works on creating educational environments that help provide a sense of safety and accomplishment for any child, but was developed for people who have been forcibly displaced due to conflict. I think several people mentioned mental health first aid on here. So I think that there is quite a bit of stuff out there, but I think it would need to be, it would very much depend on kind of what people's scope and role is and what they were doing. But there is some great curriculums out there.
Mm-hmm. This is an interesting question that just came in. ORR is Office of Refugee Resettlement, which is the entity in the federal government that oversees refugee resettlement and all the kind of work we're talking about.
It's part of the Health and Human Services Department, HHS.
So, hey, Cameron, I don't know how to unmute. Jeannie, can you unmute Cameron Stam? Jeannie, are you there? Oh, wow. There's a lot of questions. There's also questions in the Q&A. We'll take all these down, and if we don't get to them, we can do it by email, but I appreciate all these questions. Jeannie, are you there that you can unmute someone? Well, I'm going to ask Cameron's question until Jeannie can. Are there any tips on navigating intakes and counseling in light of collective cultures where families, oh, there's Cameron. Cameron?
Hi. Yeah, can you hear me okay?
Yeah, go ahead, ask your question.
Okay, so I was just wondering if there were any tips or thoughts on resources for navigating intakes and counseling in light of collective cultures where the family can be included. For example, I've encountered mothers of adult children calling on their child's behalf. And I think that things like HIPAA and other aspects of the government honor something that's more individualistic, and they don't really honor the culture that these people are coming from. And so kind of navigating the delicate balance of honoring the client and their culture and honoring the legality of the individual client that they're calling on behalf of.
Okay, thanks, Cameron. Great question. Who wants to respond? Heidi, maybe?
I'm happy to step in here, mostly to say it sounds like you're already thinking carefully about it, which is, in many ways, that's the best we can do when we're presented with these questions of how do you navigate between the systems we have and the cultures families are coming from. This is also where I find cultural brokers to be incredibly helpful. So, to be able to have a partner from the culture, maybe talk with the family about why things might look a little different or why some of the conversations need to be had in private, and to help them understand that it's not a rebuff of the families, or we don't devalue the family in this, but here are the systems and why. And so again, having someone kind of be able to broker and explain how our systems work and where we can flex and where we can't. Sometimes we can and sometimes we can't. But again, even just that you're asking that question and thinking carefully about it, I think that's what we need to do with each of these, and there's no single answer.
I'm going to jump around here. There have been a couple of questions asked about men, saying, what can we do about men? They have needs. They might, in the worst cases, be involved in alcoholism or perpetrating domestic violence. They're more reluctant to enter mental health services. What can we do about men? We need some help here.
One of the things that we've been doing is having them play sports, basketball at the Islamic Center here. It's kind of like they have been engaged. We can't talk to them directly. They wouldn't say that they're, I would say, depressed, or usually we've had very difficult time sometimes really encouraging them to work because they would say, I used to do this and this, I'm not going to be able to do this job this way. So you would see, we're really surprised to see that women are rushing to work and accepting any job that was offered from the beginning from the resettlement agencies. They were kind of like into action, like right away. So for the men, sometimes, trying to tell them how their role is important in supporting the family. I would say, again, connecting to the bigger community in the Syrian case has been really successful. Yeah, but it's challenging in general. Compared to
I guess one of the things to keep in mind is that if you imagine a group of refugees, they're families, and they're not just a cookie cutter person over and over again where everybody has the exact same needs. And this question about men gets at that, because the US government was specifically bringing some of the most vulnerable people among the refugee populations to the US, you could have families showing up, for example, where a child was a burn victim and the rest of the family was ready to get to work or get to school. And so you didn't have the same concerns about every member of the family. We also saw a lot of, when you're talking about war victims, female-headed households. So they don't have an adult male with them. It's a mom with a bunch of kids. So some of the refugee resettlement agencies were doing was, when they got a lot of women like that, was to get a couple of them to run childcare out of their home, get them up to standard so that they could do that safely. And that would then allow the other women to go. So the childcare providers would earn money, but then the moms were free to go to try to get jobs to support the family. I've also worried a lot about old people because they don't pick up the languages if they haven't already learned English. It's going to be much harder for them to learn as old folks, and so they can be very, very isolated. So the things I've seen overseas that really impressed me was, and this echoes some of what was discussed earlier about inviting people to community centers, is inviting refugees in for one thing, such as perhaps skills training, a sewing circle. I like this idea of sports, and then providing childcare at the same time so that the parents are freed up to have a conversation that isn't constantly interrupted by the kids popping up. And then also involves a psychosocial dynamic that brings people together to talk about shared problems, shared solutions. So it doesn't have the stigma attached of this one individual is being sent to a mental health facility to get care because they can't handle it, when actually they're doing remarkably well, but they need a sense of community and support.
Thanks, Anne. I'm going to let Prab ask a question. Prab, can you unmute yourself? You had some thoughts about host families?
This thought actually, came across last night. I was with a lady from Poland, and she specifically talked about her brother having a relatively sort of a house, not a formal lodging place, but a house. And they have accepted, quite a few families from Ukraine. And what she told me was that her brother and his family are feeling that in the initial excitement, compassion, concern, lots of people open their hearts and homes. Now these people are settling in, and they are seeing this relentless destruction of Ukrainian, infrastructure. Now all of a sudden, the goodwill and good gesture is gradually transitioning to becoming an anxiety disorder within the Polish family, because they don't see a future for these families in Ukraine, and therefore they feel that they're going to be stuck with this. They use the word stuck with these families for an undetermined, length of time. And the initial support that they received from the local authorities and the government, is sort of gradually fading away. And now the problem that was not theirs now has become theirs, with little or no support from the powers be. So the question that I have is, a lot of discussion that I heard has been rightfully focused on the refugees, but I don't know what is the thought, or what are the thoughts about the families that had the best of intentions, and now they themselves feel, they have become victims of this. I mean, this is apparently happening, in all over Poland, because of their initial phenomenal goodwill gesture, and they see that these people have no place to go back to, and therefore it has created its own, set of crises that are not directed, they're not affecting refugees themselves directly. Of course, it will eventually affect them as well at a different level, but the very people who have been trying to be helpful to these refugees. So any thoughts from this panel, and have you guys given some thought to that, and how do we really deal with these downstream effects of problems that used to be refugee centric? Now it is also becoming host family centric. I mean, I understand at a government level, policy level, United States, and all of that, we have infrastructure, we do all of that. But in the rest of the world, it's some other family taking on a refugee family. So it's really a profound.
Who can respond?
Who said that to me? I literally completely flabbergasted, because I never thought about those issues. Anyway, I'll stop.
And I think it's a really good point, if you don't mind me stepping in here, Steve. I think that we see some of the same thing, let's say, with unaccompanied children joining, sponsoring families within the US, both historically and also within the Afghan crisis. And the work has typically focused on the children, but not necessarily on the sponsoring family or the family reunification, which always causes some level of disruption and kind of dysregulation in the family structure, right? And I think that we'll see it more in the US, because we're looking with the Ukrainians coming to the US that they're looking for sponsoring families. But at least as of now, the support, the financial support for those families, the family has to take responsibility for lots of the support for the Ukrainians coming in. I think when you start looking at Europe and neighboring countries, this is a crisis waiting to happen because that host fatigue does happen. And you've got Poland having millions of refugees. You've got very poor neighboring countries like Moldova having significant numbers of refugees that are almost all being hosted in private settings. And, you know, the response that happened was, it happened very, very quickly. I can tell you within the emergency preparations that we were doing, you know, there was thoughts that there might be 500,000 refugees coming into Poland. The thought that there would be millions wasn't really considered at the time. So I think this is, I don't have an answer for you, but I think it goes beyond just supporting these families. It's going to go, it lends itself to another mass movement of people, which lends itself to questions around protection issues, which lends itself to where resources should be located, to supporting basic needs. But I think you're right, as this situation, as within any refugee situation, becomes much more prolonged, that new challenges and new issues unfold with that.
You know, because yesterday, by the way, happened to be the Polish Independence Day. So, and, you know, the challenge that I see, I mean, being like every one of you immersed in what's going on, this unbelievable human crisis, is that a lot of the support, you know, goes to the central. I mean, the United States, for example, Congress passes a multi-billion-dollar bill, and they give money to Ukraine, they give money to Poland, but so the resources are centrally made available, but the services are provided in an extraordinarily disparate, distributive, you know, manner. And therefore, unless the bureaucracies also of these countries are incredibly sensitive and responsive to these needs, you know, they may not even have the infrastructure to take these billions of dollars and make it available to, you know, let's say I took a family, and how do they make those resources, you know, come to me? Because they don't have that system in place. I don't know how they are registering these, you know, millions of families in Poland who are acting as hosts, and how are they making sure the support that many countries are providing actually flows to the, you know, the terminal stage of the, you know, the services that are being provided. So I think there are lots of other issues that are acute in my view. Of course, mental health issues are profoundly important, not only for the refugees, but also the host families. Anyway, so just I think something to think about, because I'm sure all of you have some influence over the policy from your intellectual contributions. So I want all of you to give some thought to these aspects, downstream aspects of, you know.
Yeah, I'm glad you raised this, Prab, and I think that we're all getting a taste of what it means to be in a complex humanitarian emergency, where, you know, not only are there individual level needs, but there are profound structural and system level needs that need to be addressed simultaneously in order to support one another. And of course, the situation in the countries bordering Ukraine is really an emergency. I mean, people didn't expect it, and it's happening. I think that one thing we might look at is the model of Turkey. How did Turkey absorb nearly 4 million Syrian refugees and provide some level of support and healthcare? I've had a chance to go there through our collaboration with the Turkish Red Crescent. I visited, we just wrote and released a report evaluating their mental health and psychosocial program in their community centers of the Turkish Red Crescent. And they've done an impressive job. And I would remind you that more than 85% of them were settled not in camps, but in communities. So in a town like Sanli-Urfa, you know, there are 3 times more refugees than there are host population. And, you know, it's pretty intense, but they are finding a way to get things done. So I think the Turkey model, well, not perfect and very challenging, provides one kind of large example of how societies can manage such
What
a
we've
large
seen, Steve, is that, you know, the neighbors around Syria really had, most had very generous impulses to allow refugees in, but
Yep.
then they had different capacities to host the refugees. Turkey was G20 country, so a relatively wealthy country with, you know, a developed society. And initially they wanted to do it all on their own, and built a lot of camps that didn't have tents so much. They had trailers and they had washers and dryers, which is something I'd never seen before in a refugee camp before. And then over time, yes, for the refugees preferred to live outside of camps. They prefer to live in cities. But if you look at Jordan and you look at Lebanon especially, at one point, Lebanon, I think that's still the case today, 1 out of 5 or 1 out of 4 people was a refugee in Lebanon, in part because they had already populations of Palestinian refugees and then Iraqi refugees and then the Syrians on top of them. And there were such close relationships between people in Damascus and Beirut. And so little Lebanon, which has a lot of issues, was really saw a disproportionate number of refugees come in that they were hosting. And the responsibility then to do something about that lays with the international community. We see the way the US responds. The US has been a leader in funding humanitarian efforts around the world, and it is a leader in funding refugee efforts around the world, top donor to the World Food Program, top donor to the UN Refugee Agency. But because there's so much going on at once now, because the numbers, as you said at the top, are so large, those resources get stretched thinner and thinner and thinner. And the we should have concerns, of course, for the polls not, you know, turning against the refugees the way, in some ways, in the Middle East, the refugees that were originally given a warm welcome started to. It was seen that they were out. What is the word? They were wearing out their welcome, and yet they couldn't go home because violence and conflict was still going on in their countries. And so we should be also concerned about countries that are not in the newspapers, further afield. You know, there are refugees from northern Nigeria who have gone into very poor neighboring countries in the Lake Chad Basin region. They too need help from the international community, but you won't read about them on the front page of any paper today.
Let me turn to others who would like to respond to these matters or anything else that you see in the chat.
I think just relative to this broader discussion that we're having, I think which got started with Prab's question, I do think it does get to this whole piece of kind of like preparing receiving communities, which we historically don't do a great job with, but which seemingly could really help with some of these bigger barriers that have been elevated today. You know, I mean, knowing that community stigma or community acceptance, knowing the need to prepare mainstream providers who may not be familiar with working with the mental health needs of refugees, you know, gearing up organizations, community leaders, et cetera, et cetera. So I think that's a whole area of work in need of more thoughtful attention and to be done in, you know, in tandem with what we're thinking about in terms of mental health and psychosocial service delivery.
I'll add one thing to that.
Okay.
Social drivers in mental health.
Yeah.
You know, I think a lot of you have put a finger on that. You know, we're not thinking about mental health apart from the social drivers that either might be driving the mental health problems, like the example that Heidi gave of a kid, or the social drivers that could help to solve or mitigate mental health problems. And so, you know, whether it's work or parenting or libraries or faith-based organizations or whatever, find ways to mobilize the social drivers in a helpful way to address the mental health issues. Okay, other thoughts, panelists?
I would say schools, to add to that. Schools in the Turkey example was a good example compared to Lebanon and Jordan. They're working more into integrating Syrian kids into free schools, no tuition, compared to the other neighboring countries. So that's also hopefully it's reducing some mental health issues as well, being part of the whole bigger society, versus being isolated in Lebanon and Jordan, where they can't afford going to private schools and they're not accepted in the schools. So again, another piece of those social drivers, as you said.
I could say I was in those schools recently, and what's the number one complaint of the Syrian kids is that they get bullied. They get bullied terribly by persons from the host community. And so people leave school because they're getting bullied. And so there's not enough support and services to address this issue. It's another social driver, a very toxic social driver that could be addressed. We know how to do bullying, but I guess it's of a scale and scope that's not addressable.
Steve, if I can just add to that, in our research with Somali adolescents, what we found is that while trauma exposure was an important predictor of mental health problems, discrimination that took place, here in their lives in resettlement was a stronger predictor of mental health symptoms. So, I think there's a temptation sometimes to think about like, oh, the problems were over there prior to coming. That was terrible, but now we have this great place and everything's going to be okay. But we can't let ourselves off the hook that easily. And actually, I think in some ways, it means there's more we can do. We have more levers to pull if we're looking at how to shape a more positive experience in resettlement. We can't change what happened, but we can change what will happen. And so really thinking about how do we build more inclusive communities? How do we, think about issues of equity and acceptance, and trying to, as you were saying, Mary, think about preparing communities. What does it mean for schools and neighborhoods and communities here? How can we do this in a way that's going to set people up for success and health in the long run?
Well, I'm really sad that we have to end because it feels like we could go on for a long, long time. But what a great discussion you all have engaged us in. So thanks very much to all the presenters. Thanks to the people listening. So we had Beth Farmer, Heidi Ellis, and Richard, Hadia Zarzour, and Mary Bunn. Thank you very much. Did a great job. This has been recorded, and I encourage people to access the recording and send it around and be in touch. This has been really excellent. Let's keep the conversation going by reaching out to panelists if you'd like, or by having more events like this at UIC or at the places where you work and live. Take care, everybody. Bye-bye.
Thank you, Steve.